All right, last but not least, we have part 4. In this lesson, Annette's going to review thermal, chemical, and electrical burns, talk about pain management, non-accidental injury, and criteria for burn center referral and transport. This is it. Let's get started.
So let's go to thermal injury alone. I want you to take a look at that top picture. Airway in danger or airway not in danger? Josh, you've seen this before, haven't you?
Yeah. I mean, maybe not even in danger from burns, but just from the fact that he's got thick tar covering his mouth, it looks like the only access to air he has is through his nose.
Right.
Oh, that'd be terrifying.
But you know, this patient is fine, right? I'm actually standing in front of this patient, asking him if I could take a picture, and then making sure that the picture was approved, etc. And so this is a patient that's doing really well. But the first thing that you see when you see this patient, if you were to receive this patient, you'd be like, "Whoa, what is this?" But really, this is just tar that's cooled down. So initially, obviously, at tar sites, if this tar bucket was dropped on a patient's head, they'd cool it initially, and this actually really kind of acts as not as a nice dressing, but it usually after it's been I can't think of the word, after it's been dissolved off, we use like a Medisol or an orange sol in these patients. We have to be really careful around the eyes, but the burn injury underneath is pretty superficial. So again, it's kind of like the chemical peel that we talked about with the whole flashback in the face. With thermal injuries, we don't do any cold water or ice. Remember that they're really prone to frostbite, and we don't want to cool these patients down. We just had a huge discussion about the triad of death. We want to avoid cooling agents, and I say this because the thing that I always hear when I'm out in the field is, can we use Burn Free? And Burn Free is a great product. It doesn't change the depth of injury, but it makes the patient feel better by covering those exposed nerve endings. But it's cooling, and so our physicians usually say that using something like a burn-free blanket, which cools the patient, is okay in a less than 10% injury. But if you have a patient with a really big burn, that's going to cool your patient really fast. And there are some transporting agencies and some agencies out there that really like the burn-free products. I'm not downing burn-free by any means. But what I am saying is that we talked a lot about maintaining a temperature. And if you're putting something cooling on a patient, then you have to check your temperature. And if they start to get cold, you have to take it off. But keeping your patient warm and keeping them dry is the best treatment of choice for this patient. And we say the basic 4 C's. The basic 4 C's are cool it, clean it, cover it, and call for help if you have a burn injury.
Oh, I like that. So just... Can he breathe through his mouth? He's just all nose breathing.
Nope. He can open his mouth. He can speak. He had his mouth closed. His eyes are actually open too. You just can't tell. But yeah, he did fine. He's fine. It looks, but again, it's distracting, right? It's just like a burn injury.
And I've seen this before, and I still panicked.
It's a good one. So let's talk about chemicals. I love these guys. So obviously with a chemical injury, they're a lot, they're managed the same as any other burn, right? You want to make sure you remove, I love this, the offending agent. That's just such a good use of words. So we want to get the chemical off. So we would remove clothes. Obviously we're talking hazmat here. We want to make sure that that's placed in an appropriate and a safe environment so that nobody else can become contaminated. If they have dry material on, we want to brush that off the skin surface before we lavage it with lots of water. And oftentimes these folks, if you guys are coming to get these patients, they've already been decontaminated, and many of you are flying, right? And so making sure that your patient isn't off-gassing prior to getting into your fixed wing or your rotor wing would be really important. Otherwise, you're all going to go down. And so I know you guys are really, really cautious about that. So let's talk a little bit about acids and alkalis. So if we look at that picture on the left, you can see that it's got it's kind of got this thick eschar to it. If you were to push on it, it would not blanch. It's really deep. And that picture is actually sulfuric acid. So this is a gentleman that had a breach of PPE. So he was wearing his PPE equipment, but the acid kind of got down his pant leg. And you can see, again, it caused a significant depth of injury. But acids and alkalis burn a little bit differently. So your acids burn by coagulation necrosis. So when acids hit the tissue, they coagulate that tissue right away. And so oftentimes acid burns are really, really painful. You want to flush that acid off. So oftentimes, because you can feel it, because it's so painful, then you're looking at maybe a decreased depth of injury because you are running to get that taken care of. Whereas alkalis burn by a process called liquefaction necrosis. So they liquefy the tissue. So the picture on the right is a gentleman that was laying wet cement. And wet cement has a pH of about 11. And so he's, kneeling down. He's in this cement. He gets these, what he thinks are pins and needles in his leg. He kind of walks it off, takes some ibuprofen, then doesn't feel any pain anymore and goes back to laying wet cement. Goes home, takes his pants off, goes to jump in the shower, and this is what he's left with. And that's because of this liquefaction process. So it penetrates down into the tissue and then it knocks out those nerve endings. And so then if there's no nerve endings, you can't feel. And so you don't even know that you've got a really deep burn that's sucked all the way down almost to bone. You can see in that picture, it's really problematic. Now both of these patients have deep injuries. Both of them ended up requiring grafting. And so really, when I ask the question, what's worse, acid or alkali, everybody always says alkali, but they can be both as bad as each other. So now let's talk about hydrofluoric acid. And it's really the fluoride ion in the hydrofluoric acid that's a problem. And hydrofluoric acids can be found in some household cleaners. They're also used for glass etching, doll's eyes making. I'm not sure who's making doll's eyes now. And then it's also a really potent cleaner that's often used in places like refineries, etc. But that fluoride ion binds to your body's calcium, and that can cause arrhythmias. So if you hook up your patient in transport to a monitor and they report having come into contact with an unknown substance, and it's really, really painful, because remember, acids will be painful, and you see arrhythmias, to ask the patient, do you have any kind of heart problem, is really important, because if they don't, then maybe it's hydrofluoric acid. And those patients can be fixed by giving them some supplemental calcium in transport. But that could be a big issue for your patient. And we want to watch for cardiac events due to that low serum calcium.
Just remember, calcium chloride should be pushed through a central line, and if you don't have one, you need to make sure you have a very solid IV line that you've checked and it's not going to infiltrate. And calcium chloride has more calcium. It has 3 times as much calcium as calcium gluconate, but both have calcium. Gluconate's a lot safer to give. That's one that we don't really carry out in the field, but the hospitals will carry it. So there's some slight differences between the two, but just be careful. First of all, don't ever slam calcium chloride. You'll put their blood pressure through the roof. You push it slow. Anyone who's conscious that's not in cardiac arrest, it takes me at least 10 minutes to get a whole amp in. So calcium chloride is a very, very dangerous drug. It's not just a bunch of electrolytes. It can, well, it is, but it can do some damage.
So let's switch paces a little bit. Let's talk about electrical injury. I love this shot. I love, first of all, Melissa Grun. She's an amazing photographer. She was one of our nurses. She just recently went over to the MICU. But if we're looking at electrical shots, this is a really great one. And you can see that first circle picture of the pediatric patient. He's had a side flash from lightning, and that's called aberration. And it's from the current passing down the body and going to ground, not necessarily entering the body, although sometimes that passage of current along the body, remember, the skin is really resistant, so it's really hard to get into our body. So oftentimes it will travel on the skin and then go to ground. But that's what that aberration looks like. But remember, that as that current goes down the body, it can oftentimes cause ignition of clothing, and that can obviously lead to substantial thermal injury. Remember, with electrical injury, CPR is the most life-saving event, and there are actually a lot of electrical injuries in this state, usually folks out hiking, and that usually ends in death because there's no one around to administer CPR. So your patient is safe once the current has gone through them, so you can administer CPR right away. And then also remember, as that current passes through the body, there's this higher incidence of spinal column injuries because of that movement of that current, and then the movement through the spine. And then these patients do require cardiac monitoring. And we don't say entrance and exit site, we say contact site, because the current, there's no rhyme or reason. If you think about the passage of current through the body, then it goes really close to bone because it's following those fluid pathways. And so as it tries to get through the tissue initially, and in fact, I'm going to flick to this next picture, and then we'll flick back to, again, you can see the urine right there. So you can see this is day of injury. So that current hit this gentleman's side right here, and you can see that charring right there as that current really tried hard to penetrate through that tissue which is initially resistant, and then all of a sudden now it gets into the body and it flows through the path of least resistance, and then it wants to exit to ground. So, and then as it tries to exit to ground, there's no rhyme or reason behind its distribution. So it will kind of flow to moist areas. So it will flow kind of to the groin between the buttocks. It will flow to the armpits, and then it will flow to ground. So it will kind of bounce around. And that's why we don't really say typically entrance and exit site, because we're not quite sure what's really the entrance and what is the exit, although sometimes that can be definitive. But you can see this is day of injury right here. This is post-injury day 3. So we know that this is 3rd degree. There's no doubt in our minds that this patient needs to be debrided. Oftentimes for electrical injuries also, we want to see what kind of damage is underneath on that patient. So we took this patient to the operating room really quickly. Now we're left with a really nice granulating wound bed, healthy wound bed right there on that side right there. And then post-injury day 10, and then again day 23 with a skin graft on this patient. So electrical injuries are pretty devastating injuries. That electrical flash can also cause cataracts. So if a patient reports this progressive difficulty seeing, it might not be their aging, it might be cataract formation. So to keep that in mind also is really important. And then the other thing that's really important too is as that passage of current goes through the brain, remember it can kind of rewire, if you will, the way a person thinks. So it may be that the person was really sweet and supportive, and now after being hit by lightning they may have anger management issues, and so to think about that post-injury, because obviously the first priority is to take care of the injury and the trauma that has been sustained, but down the line these are where our post-discharge programs come into play, so that we can keep an eye on these survivors and make sure that they're doing okay in other ways. And then if I flick back to that picture of the urine, this is typically something that we'll see in our electrical injury patients. Remember, we talked a little bit about that earlier. And this is deep muscle destruction. So this is myoglobinuria. And in a patient with an electrical injury, in a typical adult, we normally want around 30 to 50 mils of urine. We're going to double that in a patient that has myoglobinuria. And then in a pediatric patient, instead of the 1 mil per kilogram, we're going to want 2 mils per kilogram to flush those big molecules out of the renal tubules so that patient doesn't go into renal failure. And oftentimes, electrically injured patients do end up on dialysis, and usually do really well, especially because a lot of the patients we see seem to be young and pretty healthy. So let's talk a little bit about pain management. Remember, burns hurt, and then they are also anxiety provoking. So if this was your thigh area, you would be scared, you would be frightened, you would be anxious, and that would increase that pain response. And so one of the most important things that you can do as a transporting agency and as a critical care provider is educate the patient about why they hurt, and then cover it up so they can't continue to see that area that's anxiety provoking. Remember to give small amounts frequently with reassessment, because these burn patients, they can take an awful lot of narcotics and still not report any decrease in their level of pain. But if you're giving a lot of narcotics to a non-intubated patient, now you're in danger of that patient stopping breathing, and so making sure that reassessment is done. And they may never be pain-free. They may always report a 10 of 10. And then the other thing to think about is the trauma of the event. You know, the middle picture is of a fire again in Cottonwood Heights that was caused by fireworks this year, and luckily there was no one injured. But if your house is on fire, and especially as a child or even as an adult, you're trying to get out of this house, and then you sustain a burn injury, the trauma of that event can be really significant. And again, you're going to be looking at an increased level of pain. That picture on the right is of a donor site. I just wanted to slip that in. So if you'd never seen a donor sites are very, very painful because the skin is taken very superficially, so there's a lot of nerve endings exposed. And so not only is the burn painful, but the fix of the burn is also really painful. So let's talk a little bit as we head into close about non-accidental trauma. NAT, as it's otherwise known, is actually pretty huge in the state, and burns is a common method of inducing NAT. And so obviously as a provider, we know that if there's a suspicion, there's a legal obligation, number one, to report it. And then number two, you know, as providers, I think we've got this spidey sense. If it was to do with money, we'd be killer on Wall Street, but it's not. It's usually to do with our patients, which doesn't bring much money in at all. And so you know, when you're receiving report or you're talking to a patient, when your hair stands up on the back of your neck, that's an indication that there's something wrong. And with non-accidental trauma, this oftentimes occurs at potty training age. And let's just talk about this for a minute so none of us are judging here. If you didn't know that barista poured hot coffee was 180, if you didn't know that your hot water heater would be set at 146 if you haven't already turned it down and could cause a burn in a couple of seconds, then you can kind of sympathize with this here. So you've got a crying kid, and you're trying to potty train them, and you haven't maybe slept in a couple of nights. Maybe you're working 2 or 3 jobs. Maybe you've got a sick kid. I mean, there's all kinds of excuses, but you run a bathtub and you crank on the hot and you turn on the cold a little bit, because the hot's the first one you come to, and then there's the cold. And you don't do the smushy thing with the water, and you don't do the elbow dunk, you're tired, and you set your child in the water. So this isn't always necessarily intentional. It is sometimes a fact of that the person just didn't know how the water could burn, right? But sometimes this is intentional. But what usually happens, and it's around potty training age, is the patient soils their panties one too many times. The caregiver takes the child, places them in water that is a little bit too hot, and it holds them in place. Initially, the child will cry and pull up their knees, so there's often an area of sparing behind the knees. But regardless of all of that, there's a clear differentiation between where the water hit and where it did not. There's no splash marks. So that would be something that would be important to note. The other story that is usually given by the child is kind of the exact same story. So they would report to first responders. The kid's story, if we're asking, so the first responders are really crucial, and then transporting agency, and then us, and then we always refer our patients to Safe and Healthy Families at Primary Children's. Anyone under the age of 5 usually gets referred. But if you were burn injured, Josh, I might say to you, "Hey, Josh, I'm going to help you. What happened?" And you might say, "Well, I put my hand under the hot tap and I didn't realize it would be so hot, and I burned myself." And then when the patient gets to the hospital, I might ask that same question: "Hey, Josh, how did you burn yourself?" And you'll say, "I put my hand under the hot tap and I didn't realize it was so hot, and I burned myself." And when we refer to Safe and Healthy Families, a couple of days later, and they come and look at the child and they take a picture and they say to you, Josh, hey Josh, how did this happen? Again, you respond with, well, I put my hand into the hot tap and I didn't realize it would be so hot and I burned myself. So there you've got 3 exact matching stories. Whereas the caregiver's story oftentimes changes as they add or delete something that is less incriminating to them. And so now you've got 3 unmatching stories. And so that's kind of how we are able to tell whether it's non-accidental trauma, and a bunch of other things. Obviously, Safe and Healthy Families does an investigation, etc. But in my years on the burn unit, the thing that really kind of plays out in my mind is you can't ever look at someone and think they didn't do it, because the reality is that most folks that do it just look like you or I. And you can't really pick out a person that would inflict this kind of injury on a child. So I put one slide in here that says, so what do I do with a wound? Because I always get asked this by transporting agencies or by folks that pick up with burns, and I put a series of pictures on here, but none of them are relevant because you don't have to do anything with the wound. You don't have to debride it. That's the last thing you really want to do. You can wrap it with dry Curlex if you want. If you got an extended transport and you want to stop maybe the patient from looking at their injuries and from weeping all over your fixed wing, or you can just leave them open and you can put a blanket over the patient. It doesn't matter. You don't have to do anything with the wound. And so putting dries on wouldn't be the wrong answer, and putting a blanket over the patient wouldn't be the wrong answer too. We talked a little bit about burn-free. Wrapping them in a cooling blanket is probably not a good idea. If there's a smaller burn injury and it is helpful in a small area, then maybe that would be okay. But I did put this sequence in here so you could see that this is a hot grease injury. This is with a nice blister formation on day 1 and day 2. By day 8, you can see it looks fabulous, and by day 13, it's really healed. And then I put one of the common topicals that we've talked about all through this presentation. Silver sulfodiazine. I know it's old school, but we still use it. There's a lot of silver products that are used, and then bacitracin is the other one. So what do I do with the wound? What do you do with the wound? Nothing.
I like that. It simplifies this whole process. We get these patients, we think it's a serious life-threatening thing, and you think, oh, what do I need to do? I've got so much I got to do here. Cover them up. Give them some pain meds. Make sure there's not an airway issue, and give them some fluids.
Same as what you do for every other patient. Yeah. So there is a referral criteria that the American Burn Association has. Again, telemedicine is a great option because perhaps these patients don't need to be transported, and we can assist the facility that has the patient take care of the patient, which is really oftentimes the right thing to do so they can stay in their local community. We can also assist burn provider. We can assist non-burn providers know how to take care of a less acute injury so that they can then take care of their community. So, but these are the referral criteria, and they kind of make sense. It looks a little bit like we want everybody, but we really don't want everybody. But if we look at number 2, for example, burns over a joint, the face, the perineum, the hands, or the feet. One of those pictures that we saw earlier that was in the slide with let's do a review of depth of injury was a picture of a hand with a patient that had sustained a campfire injury, and that was the one that was kind of hard to see but was a very deep injury on the finger. So if you think about your child going into a campfire, so now they've got a really small injury, way less than 1%, right? So but it's on the hand, and it's on kind of the finger, and it's kind of on the palmar surface area. If that burn isn't treated accurately, now you've got a patient that now doesn't have good range of motion on a hand. So that's why, referring patients or requesting referral of those patients, even with smaller injuries, is really a good idea because of the burn therapy and the releases they could potentially need in the future. And then the rest kind of all makes sense, and I'll let you read through those. I don't need to read them to you, but telemedicine is a really great way to go. That transferring of digital images, again, can say 1,000 words. So as we move into packaging concepts, necessary for transport. Obviously, number one is secure the airway. Number two is adhere to fluid protocols. We've talked a lot about airway and fluid. We've talked a lot about keeping the patient warm. And I think we've mentioned at least 20 times not to get distracted by the very visual nature of these burns. We've talked a lot about that pain and anxiety is important, and relieving that with your patient and explaining to them what is going on is really important, so their anxiety level will be decreased. And then always, 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 if you've never even taken care of a burn patient before, you will be just fine as long as you adhere to the standard principles of ATLS, which is your primary and your secondary survey. Burn consult if needed. If before you set off the hair on the back of your neck stands up and it feels like that spidey sense is going on, call the burn center if they're being transferred to us, and talk to us about what you feel like is going on with your patient, because it's much better that the patient is stabilized in a controlled environment than up in the air when you guys are transporting that patient. And then adjust based on patient response. Obviously, we talked about if Josh and I were burned, we may react differently. So Josh may react different to me, and adjust whatever you need to, fluids or heat or whatever it is based on the response. And then the reality is that you guys know how to do this. You just need to do what you do every day. It's like Thane riding a bike, and Thane's wearing a Hello Kitty outfit because he's trying to make some small child laugh. We don't usually wear this for work, but you guys, this patient is just like every other patient. They just have a burn, so just ride your bike, do what you do, and then put in the back burner that this patient could have some fluid issues and some airway issues that maybe another patient population wouldn't have. And I personally, I love this picture because you could be riding your bike and you could be thinking, oh man, I got this. I am on this patient. And then all of a sudden you're thrown off by some curveball, and we call that experience, right? So I've got to tell the picture of the porta potty right here. So I was volunteering in Baton for the Memorial Death March, and I can't even tell you how many hundreds of hours were spent into locating where the landing zones were for the Blackhawks, and where the porta potties were going to go. And the aid station that I was at, I think we flew 6 patients out via Blackhawk because they were doing this marathon in these extreme heat conditions across the desert. And the first time a Blackhawk landed, it knocked over the porta potties. And again, many hours had been spent in planning. And so sometimes it doesn't matter how experienced or how much you've planned or how much thought you've put into something. The porta potties are going to fall over, and you
Tell
just
me no
need
one
to
was
be
in there.
flexible. Nobody, I don't think, was in that one. But the next year I was there again. Lots of thought because we've got knocked over porta potties, right? So the next year I was there. I was in a different medical area, and there was a massive wind came through the canyons and it knocked the porta potties over. So this time they were far enough away from the landing zone.
Still.
Sometimes best laid plans, right? It's awesome. So be flexible, and adjust with your patient and adjust with the flow, right? I mean, sometimes there are situations that can't be avoided. So just in closure, the last couple of slides, I want you to know that despite all of these pictures we've seen, and this is kind of where Josh started us out at, was wow, these are really graphic. Most burn patients survive. Remember that survivability was very, very high. And so what I want you to know is that if you have a burn patient, that you can call us. We would be happy to give you a report on that patient. And we can allow you to have that information, because as a transporting agency you need closure so that you don't think that patient didn't make it, because the reality is most patients do. And if you're in the area and you want to come visit, I will tell you that most patients, when we say that the provider that flew them or the transporting agency would like to come say hi, they would love you to come in. So please feel like you can do that, and don't get discouraged thinking, man, that patient probably isn't going to make it, because they probably did. And the road is long, right? I mean, this picture just kind of makes me tear up a little every time I see it. But this is a patient that had been in the burn unit for a really long time. And when our patients are discharged, or they get discharged to even an extended facility or a skilled nursing facility, then we're still really happy for them, because it means that they've made a transition out of the hospital into a less acute area. And so we usually form a line. All of our disciplines kind of form a line, and we high five and we hoot and we holler and we yell as the patient kind of gets escorted out by you guys that would be transporting this patient to another definitive care site. And this is a really good day. And so even though the road is long, know that there's a lot of incredible moments, and we are super grateful for our patients and for the journey and for all that they teach us, because I think they teach us just as much as we teach them. So second to last slide. I know you guys are like, man, she talks a lot. But the real point that I want to make is that it really does take a village. It takes the EMS on scene. It takes the transporting agency. And I love this slide of our life flight and our AirMed folks kind of hugging each other. It's super awesome. It takes our fire department members to drag those folks out of the fire, and sometimes it takes our military. I love the shot in the middle, and then the burn center as the definitive care site most often. But the thing that's important is the patient in the middle. We all have to work together. We all have to keep the patient warm in order to avoid that triad of death. We all have to do our part in order to make sure that patient has the best possible outcomes. So it really does take a village. And I want to say a big thank you right before we go to the last slide for all of you that are transporting our patients, and for the incredible job that you do, because you guys do an amazing job. So thank you. And I love this quote. And I love that ability to look back. And I love this mirror shot of the sunset, because we don't learn by doing, we learn by reflecting on what we've done. And so I would just in closing say, for those patient transports that you have done, review them with your peers. Chat with Josh about them if you're in school. Reflect on what was done and what could potentially be done differently in the future. Maybe not even better, but maybe just done differently. And share that with your peers, with your colleagues, with your friends, with anyone that you can, because if you can learn something and share that, then a part of you has really become immortal in another person that may end up either saving a patient's life or by improving their morbidity and mortality by learning from something that has been done from another. And so I think that's really, really important. And then the other piece of that is reflecting on literature. We talked about evidence surrounding hypothermia. We've talked about evidence surrounding fluid administration. So to learn by what is evidence, and to not continue doing something that is not evidence-based would be really important, and again increases our patients' morbidity and mortality. So thank you for your time.
Thank you, Annette. That was fantastic. I would just like to say I've done a few rotations in the burn center, and I have never been in a unit that is more professional. Everyone there, it doesn't matter if you're a doctor, a tech, a nurse, they work together as a team. They respect each other, and they're amazing, and they care. And you look at these burn center nurses, they're pediatric nurses, they're ICU nurses, they're geriatric nurses, and they're not just taking care of this patient for a few days and then they're gone. You really get involved with the patient's family, and it is really this there's this family feeling up there with the patients and their families and the staff, and there's really nowhere quite like the burn center. And so for any of you listening today, if you get a chance to do a rotation up there, it is amazing. So thanks for what you do.
Yeah, no, we call it the cocoon of love, and it's not for everyone. There's going to be some of you that watched today that think, man, I never want to take care of a burn patient. But there are some of you that maybe you've got the burn bug, and we're happy to show you around our cocoon and assist you if you want to, in maybe doing some rotations with us. There's ways that we can do that. So let us know.
Thank you.